Hello, and welcome you all to my YouTube channel. Today, we will learn about topic, core ear surgeries, Myringotomy, Mastoidectomies, and Myringoplasty. First, Myringotomy or tympanostomy. Definition, incision in the tympanic membrane. Primary goal, drainage of middle ear effusion, suppurative or serous, and/or aeration. Key indications, acute otitis media, bulging TM with severe pain, incomplete resolution or intratemporal complications, facial paralysis, or labyrinthitis. Otitis media with effusion, persistent fluid greater than 3 months with hearing loss, recurrent AOM to break the cycle of infection, atelectic ear or eustachian tube dysfunction for long-term ventilation, requires grommet. Anesthesia, GA in children, LA or none in non-inflamed adult ears. Critical anatomy, incisions, posterior inferior quadrant for drainage, anterior superior quadrant for grommet placement, longer retention. Pitfalls, avoid the incudostopedial joint posteriorly. Beware of vascular anomalies, high jugular bulb or aberrant carotid. Grommet or ventilation tube. Purpose, maintains patency of the myringotomy. Complications, otorrhea, blockage, premature extrusion, persistent perforation around 2%, and tympanosclerosis. Post-op, keep ear dry. Grommets typically extrude in 6 to 18 months. Second, mastoidectomy, the triad. General concept, surgery of the mastoid air cell system, often for cholesteatoma or chronic infection. 1. Classification based on extent of dissection. A. Cortical mastoidectomy. Goal, accentuate all mastoid air cells. Posterior canal wall is left intact. Indication, acute coalescent mastoiditis. Landmarks to identify, tegmen, dural plate, sigmoid sinus plate, horizontal semicircular canal, digastric ridge, points to facial nerve. This is the anatomy lesson procedure. B. Radical mastoidectomy. Goal, create a single, exteriorized cavity for disease control, no hearing preservation. Key steps, remove posterior canal wall, remove bridge and buttresses lateral attic wall, lower the facial ridge, safer access to cavity, remove all disease, tympanic membrane remnant, malleus and incus, leave stapes, obliterate eustachian tube, perform medioplasty, widen the meatus. Indication, unreconstructible ear, extensive cholesteatoma, palliation. C. Modified radical mastoidectomy. Goal, exteriorize disease while preserving reconstructible elements. Difference from radical is that the surgeon preserves what is healthy, tympanic membrane remnant, functional ossicles, mucosal lining for potential future hearing reconstruction, tympanoplasty. Indication, cholesteatoma confined to attic or antrum. 2. Based on canal wall fate, most common. A. Canal wall up. The posterior bony ear canal wall is preserved. This maintains a normal-looking ear anatomy but requires meticulous technique and often a second-look surgery to check for hidden recurrence. B. Canal wall down. The posterior bony ear canal wall is removed. This provides superior visualization, reduces recurrence rates, but creates a permanent mastoid cavity that requires lifelong care and cleaning. 3. Specific procedures. Combined approach tympanoplasty, a 2-stage canal wall up procedure involving mastoidectomy plus facial recess approach plus tympanic membrane repair. Atticotomy, opening only the attic or epitympanum. Attico-antrotomy, opening the attic and the mastoid antrum. 3. Myringoplasty. Definition, closure of a TM perforation in an otherwise normal middle ear. Versus tympanoplasty. Tympanoplasty includes middle ear exploration and a succular chain reconstruction. Myringoplasty is a subset of type 1 tympanoplasty. Graft materials, temporalis fascia, gold standard, tragal perichondrium, or cartilage. Techniques, underlay, graft placed medial to TM. Pros, lower risk of iatrogenic cholesteatoma. Cons, risk of graft medialization and anterior blunting. Overlay, graft placed lateral to TM remnant. Pros, excellent graft take. Cons, technically harder, risk of epithelial pearls, buried skin cysts, and lateralization. Key principle, meticulous de-epithelialization of the perforation margin is critical for success to prevent cholesteatoma. Alternatives for small perfs, cautery patching, trichloroacetic acid, fat graft Myringoplasty. Fourth, surgical approaches. Endaral, Limpert's incision, between tragus and helix. For canal procedures, Attic disease. Postaural, behind the ear, gold standard for mastoid surgery. In infants, make it more horizontal to avoid the superficial facial nerve. Transcanal, Rosen incision, through the ear canal for Myringoplasty, Mastoidectomy. It requires a wide canal. If you found this breakdown helpful, please give this video a thumbs up and hit that subscribe button so you don't miss our next tutorial. Let us know in the comments what other ENT topics you'd like us to cover.